Good evening, good afternoon, and good morning. This is the 1595th day of continuous webinar conducted by International Forum for Promoting Homeopathy. Today, our guest is Dr. P. SREE LEKSHMI from, thank you all. The International Forum for Promoting Homeopathy comprises of homeopathic lovers, students, and doctors, and we have 3 sessions every day. The first session of the day is already over in Hindi, that's from 7:30 to 8:30, and we have an international session from 8:30 to 9:30, and a local language session from 9:30 to 10:30. All the sessions are going in a good way, and we are uploading the videos of the same on the very next day itself, so that those who miss the session can watch it, as well as you can share it with your friends around the world, and you can subscribe the same without paying a penny. That is the beauty of International Forum for Promoting Homeopathy. The purpose of this forum is to take homeopathy to every home around the world. And we are targeting such a big thing in a good way. And that's why we are about to begin some more language sessions, in local language sessions in the coming days also. We have already done a lot of good work in promoting homeopathy, as well as in protecting homeopathy and connecting doctors around the world. These are the things we have achieved already. And let me come to today's session. As you all know that we have a session from Dr. P. SREE LEKSHMI. She has completed a BHMS and from Kerala, and is now working at, she is staying at Qatar with her husband and doing online practice from there. And today, Dr. will be discussing about management of diabetes mellitus with homeopathy. As you all know that it's a big day for us, because it's a big thing that almost 1/3 of the people around the world are getting such a disease, and it become a lifestyle problem all over the world also. Some people believe that it's a disease. Some people believe that it's not at all a disease. It is something else. So let us see what Dr. SREE LEKSHMI has to say about this. And it being a big subject, we will have 2 sessions from Dr. P. SREE LEKSHMI to complete the session. So hope you will enjoy the session. You will support her from your point of view. Thank you all. Let us begin the session, and we proudly welcome Dr. SREE LEKSHMI for the same. You are already the co-host. You can go ahead with the session.
Thank you, sir. Can I screen share?
Yes. Doctor, your friend has not raised the hand. See it.
Another SREE LEKSHMI piece there, sir.
Okay.
Can another SREE LEKSHMI piece there? Can you make him co-host? Another SREE LEKSHMI piece there.
Yes. I have seen that. Okay. Okay, I have done it. Okay, you can go ahead with the presentation.
Is it visible now, sir?
No. The screen, you have no. Please reshare. You close the screen sharing and then restart.
Yeah, other SREE LEKSHMI P.
Yes, it is coming. It is coming now. Okay. Now you can go ahead with the presentation.
Okay.
Really fine for you.
Okay, thank you, sir. Good evening, everyone. Today's my topic is management of diabetes mellitus with homeopathy. Before going to the topic, I would like to thank each and every person behind IFPH for creating such a wonderful platform through which the homeopaths from among the world can connect each other and share their views, their thoughts, their experiences, knowledge, and their treatment methodologies and their insights. Attending it directly or watching it later in YouTube became one of my habits, and through which I could obtain a lot of information, such as bachelor remedies, then different styles of treatment by our different doctors, different medicines in depth, and so many other things. I'm extremely thankful to Abdul Salam sir for inviting me here and for giving me all the supports and confidence. And I would like to remember and thank my teachers, my parents, and my family members for their blessings and support. Let's talk about diabetes mellitus now. The doctors here are experts in treatment of in management of diabetes mellitus. So I'm focusing on the students here. The students, those who are attending the session, should get something from me. So I will go a little bit slowly. And to the doctors, please correct me if there is any mistakes from my side. And to know about the management of diabetes mellitus, we should know what is diabetes mellitus. Diabetes mellitus in detail. Diabetes mellitus is not a single disease. It's a group of diseases. That's why it is called as a clinical syndrome. So, diabetes mellitus is a clinical syndrome characterized by chronic hyperglycemia or increased plasma glucose level. Many metabolic disorders are put together due to some commonalities. All of them have a tendency for chronic hyperglycemia. So, we can define diabetes mellitus as a group of metabolic disorders characterized by chronic hyperglycemia associated with disturbance of carbohydrate, fat, and protein metabolism due to absolute or relative deficiency in insulin secretion and or its action. Not only carbohydrate metabolism is getting affected here, but also protein and fat metabolism is getting disturbed. So the very important thing here we have to remember is in every 5 seconds, one person in the world is dying due to acute or chronic complications of this disease. And globally, around 500 million people are getting affected with this disease. And in some countries, among 5 people, 1 is getting affected with this disease. So now you can understand how dangerous is this disease. Based on the cause, we can classify it mainly into 2 types. That is type 1 diabetes, insulin dependent diabetes, and type 2 diabetes, which is non-insulin dependent diabetes. Insulin dependent means the insulin secretion in our body is reduced due to decreased secretion of insulin in our body. And non-insulin dependent means the insulin level is normal, but body's resistance against insulin is very high. That is, type 1 is due to decreased production of insulin, whereas type 2 is due to increased resistance towards insulin by our body. Some other classifications are also there. Let's discuss it later. Let's take a deeper look into type 1 diabetes. Type 1 is generally considered as a T-cell mediated autoimmune disease, which causes destruction of insulin secreting beta cells of islets of Langerhans of pancreas. That is an autoimmune disease, T-cell mediated, and it is causing destruction of the only the beta cells of pancreas. Beta cells are secreting insulin. We all know that pancreas is having other cells also, like alpha and delta cells. Alpha cells secrete glucagon and delta cells secrete somatostatin. These cells and its functions are occurring normally, and only the beta cells are targeted by our own autoimmune cells. It is usually occurring in an younger age group, that is less than 40 years. Usually it occurs between 5 to 7 years or in the adolescent age group, especially before the age of 40 years. Here the classical symptoms of diabetes mellitus start to appear when 80 to 90% of the beta cells, functionals of the beta cells have been lost only. That is, when 80 to 90% of the beta cells are being destroyed only, the symptoms of diabetes mellitus, type 1 diabetes mellitus start to appear. It will take months to years to lose the functions of this much of beta cells. In some cases, it will take a very few months, but in some other cases, it will take so many years. Until these years, about 40 to 50% of the beta cells remain intact or it remained viable during this period. So this case remain undetermined or undiagnosed, so that it will end up with diabetic ketoacidosis. When the diabetic ketoacidosis start to appear only, we can understand that this person or this patient is suffering from type 1 diabetes. And diabetic ketoacidosis is the medical emergency situation in diabetes mellitus. I already told that the destructive process is mainly concentrating on the beta cells of pancreas. So that number of theories such as molecular mimicry, oxidative stress, and viral infections have been postulated, even though the specific mechanism for inducing autoimmunity in type 1 diabetes is unknown. The genetic predisposition of type 1 diabetes is shown in the slide. That is, if a patient is diagnosed as type 1 diabetic, then what is the chance to develop? How much is the chance to develop the same disease in his close relatives, that is first degree relatives? For identical twins, it will be 30 to 50%. For non-identical twin, it will be 6 to 10%. HLA identical sibling, it will be 16%. Non-HLA identical twin, it will be 5%. For father, 10% chance is there. For mother, 1 to 4% chance is there. For both parents, up to 30% chance is there to develop type 1 diabetes. Now you think why this is affecting the father and mother of this individual, as it is affecting in early age group people, that we will discuss later. When the patient with type 1 diabetes is crossed a threshold at which the insulin secretion and the normal blood glucose level can no longer be sustained. That is, as the destruction takes place in the beta cells, the insulin secretion is getting reduced. And as the insulin is reducing, the glucose level in the blood is going on increasing. At certain limit, above certain level, the increased blood glucose level itself act as a toxin to the remaining beta cells of pancreas. That is, first our autoimmune cells will destruct our beta cells, and next our increased blood glucose level itself destruct our remaining beta cells. That's how about 80 to 90% of these beta cells is getting destroyed this much faster, and where the symptoms start to appear. So the profound insulin deficiency rapidly causes metabolic changes. As I told, it is not only affecting metabolism of carbohydrates, but also it's disturbing lipid as well as protein metabolism. About the metabolic changes, let's discuss in diabetic ketoacidosis or in the metabolic changes of type 1 diabetes. Now we saw that some autoantibodies are destroying our beta cells of pancreas. Let's take a look into that. Even though they are identifiable, it can be present long before the clinical presentation. That is, long before the clinical presentation starts, these autoantibodies are present in the blood. About 40 to 50% of beta cells remain viable in some cases, that we all know, so that their detection will be useful in confirming the diagnosis of the patient. That is, this patient will develop type 1 diabetes within some years. We can diagnose it as like that, but the prognosis of the disease or the disease progression we cannot predict by the detection of these autoantibodies in our body. And also, as time passes, as the disease progresses, these autoantibodies start to disappear from the blood. Then type 2 diabetes. What is happening in type 2 diabetes? It is usually occurring in older age group, especially after 50 years of age. In type 1, it is occurring in younger age group below 40 years, whereas type 2 is occurring above 50 years of age. Its natural history is shown in the figure, that graph you can see. That is, type 2 is occurring due to increased insulin resistance of our body tissues. That is, insulin receptors are very relatively reduced. Here, initially, as the resistance increases, the blood glucose level will not reduce. As the insulin level again increases, the blood glucose level will not come down, and the beta cells produce more and more insulin to balance the blood glucose level. So that after a certain limit, these beta cells become tired of, and it cannot produce more insulin, because it will get shriveled off and it cannot function properly after that. At that time only insulin deficiency start to appear in case of type 2 diabetes. Till then insulin will be there, but only the resistance will be more in case of type 2 diabetes. Then in type 2 diabetes, because of the presence of this insulin resistance, there will be a pre-diabetic antecedents, including hypertension, dyslipidemia, that is elevated LDL and triglycerides level, and low levels of HDL, and non-alcoholic fatty liver diseases. In women, conditions such as PCOS can appear in these cases. This is termed as insulin resistant syndrome or metabolic syndrome. Because of the metabolic changes happening in the body due to the insulin resistance, these all symptoms are appearing, and before patient presenting with insulin deficiency or diabetes mellitus, presenting as a diabetic patient, all these symptoms are starting to appear. These symptoms are again more common in obese individuals. The primary cause of insulin resistance remains unclear now also. Anyway, in obese individuals, the central pad of fat, that means intra-abdominal pad of fat, adipose tissue is metabolically active. It releases large quantities of free fatty acids, which can give fuel to the peripheral tissues such as our muscles and other body parts. Then these peripheral tissues are getting free fatty acids instead of glucose, so that again this glucose level in the blood remains higher, that is hyperglycemia occurs. These central pad of fat, central adipose tissue again secretes some hormones and also some peptides like adipokinase, which are structurally similar to cytokines and capable of affecting the sensitivity of insulin receptors. The insulin receptor sensitivity is getting affected, and it can no longer act as receptors anymore, and this insulin resistance again increases in our body. Then physical inactivity again causes increased blood sugar levels. That is, it again causes downregulation of the insulin sensitive kinase and may promote accumulation of free fatty acid within the muscles. Sedentary people are therefore more insulin resistant than active people with obesity. So we can find the risk factors here are the age. First one is age, after the age of 50 years. Then obesity and physical inactivity. Diet. Nowadays we are all taking high sugar containing diet. That is, food with a high glycemic index we are taking, and also sugary drinks. These all taking part in the development of type 2 diabetes. Then genetic predisposition is also there. Then ethnicity is also there, contributing the development of type 2 diabetes. Some other forms of diabetes mellitus include latent autoimmune diabetes of adults, or we can call it as LADA. latent autoimmune diabetes of adults. I have already told that type 1 diabetes is usually seen in younger age group, but here in LADA, some autoimmune destruction of beta cells start to occur in later age group. In Davidson, it is given as LADA is given under type 1 diabetes as a subset of it. Then even it occurs in later life, how can we find it out as type 1 diabetes? Usually type 1 diabetes is occurring in younger age group, and in older age group type 2 only affecting. When it comes for older people, how we can find it out as type 1 diabetes? That is, they do progress rapidly to insulin requiring stage. Usually, insulin requiring stage only happens after a longer period of time in type 2 diabetes. But in type 1, insulin deficiency is the primary symptom. That's how we can understand this is the latent autoimmune disease of adults. Then next one is maturity onset diabetes of young people. We can also call it as MODY, M-O-D-Y. It's under monogenic diabetes in Davidson. Then insulin is there, but its receptors are absent in younger age group. So we can define it as non-insulin requiring diabetes that develops under the age of 25 years. And also neonatal diabetes comes under this maturity onset diabetes of young people. That is type 2 like diabetes in young people below the age of 25 years. Type 2 diabetes is occurring. Then gestational diabetes. In women during their gestational period, gestational diabetes is occurring in women during their gestational period. It is because of the action of hormones, that is placental hormones that is secreting during the time of pregnancy, and this can cause this resistance against what this insulin secretion, insulin action. This could be the reason for developing gestational diabetes, and also beta cells destruction, not beta cell destruction, beta cell secreting insulin level can also be reduced in some cases. Anyway, there is chance to disappear this along with the delivery occurs, and in some cases, but their chance to develop type 2 diabetes is higher in these ladies. Then secondary diabetes mellitus. The drug-induced diabetes and disease diabetes due to some other diseases can also occur as secondary diabetes. Drug-induced diabetes means in case of long-term use of some drugs like beta blockers, some diuretics, we can develop chronic hyperglycemia. That we can include under drug-induced diabetes. Some other disease also occurring as drug-induced diseases, but as secondary to drug, this diabetes mellitus occurring in this case. And also pancreatic CA, Cushing syndrome, like endocrine disorders, also take part in this secondary diabetes mellitus. Chronic alcohol excess can result in recurrent bouts of pancreatitis, in turn lead to destruction of pancreatic beta cells and can result in diabetes mellitus. And some other chronic calcific pancreatitis occurring in some endemic areas. Here, the alcoholism is not a cause of diabetes, or alcoholism is not a cause of destruction of beta cells. It is occurring only due to calcification of pancreas. and also in turn resulting secondary diabetes mellitus. And also genetic defects of beta cell function, genetic defects of insulin action can result in type 2 other types of diabetes, can including other type of diabetic mellitus. Then drug induced diabetes can include associated with the genetic syndrome such as Down syndrome, Klinefelter syndrome, Towner syndrome, Wolfram syndrome, Frederick's ataxia, myotonic dystrophy. In all these cases, diabetes also can occur. These are the different types of diabetes occurring in our body. Then the symptoms of hyperglycemia. Let's see what are the symptoms of hyperglycemia and why these symptoms are occurring. As the blood glucose level is very high, the blood passing through our nephrons also carrying this much quantity of glucose in with them. So what happens? This our glomeruli is very transparent or permeable to glucose molecules. This glucose is getting filtered by the Bowman's capsule, and while it is passing through the nephrons, it will get reabsorbed back into the blood. But in severe cases of diabetes, it will not happen. That glucose will excreted through urine, and this is called glycosuria. This only occur as a later effect only. But as the glucose is pulling much amount of water also through this, along with this glomerular filtrate, the poor reabsorption, which in turn result in polyuria, that is the water reabsorption also occurring very slowly, and this result in polyuria. And then this diuresis again result in dehydration, and our thirst centers are getting activated, and we are feeling thirsty, that is polydipsia. Now polyuria, polydipsia, then polyphagia. When the blood glucose level is, even though the blood glucose level is very high, our tissues are getting only very low amount of glucose. By identifying this, the information passes to brain that the tissues are having only low amount of glucose to utilize. This will in turn result in polyphagia. We will feel more hungry. It is polyphagia. Then rapid blood flow through these nephrons again result in defective reabsorption of electrolytes also, which causes electrolyte imbalance in our blood. And this electrolyte imbalance in later life can cause atheromas in the blood blood vessel endothelium. As the osmolarity of blood is getting increased, the endothelium getting damaged, and the atheromas start to develop. These increased osmolarity of blood can result in irritation in the brain, so that tiredness, nausea, headache, mood changes, irritability, difficulty in concentrating, apathy like symptoms can occur. Then other symptoms include nocturia, then change in weight. It could be weight gain or weight loss. In case of type 1 diabetes, it will be weight loss, and type 2 patient will be already obese. Then the other changes include pruritus vulva or balanitis due to genital infections. We are getting more prone to develop infections also. Then let's discuss about the metabolic disturbance in type 1 diabetes. Now we all know that how profound insulin deficiency is occurring in type 1 diabetes. This profound rapid insulin deficiency causes decreased glucose uptake and insulin utilization by our body tissues. That is, profound insulin decrease. Profound insulin deficiency occurs in our body due to the rapid destruction of beta cells and also due to glucose action. As a result of action of glucose, also beta cells are getting destroyed. This together happens, and this will cause profound insulin deficiency, and this in turn result in hyperglycemia. This extreme deficiency of insulin causes another changes in endocrine system. That is, counter-regulatory hormones are there in our body. When the insulin level is getting reduced, these counter-regulatory hormones start to appear in our bloodstream. These counter-regulatory hormones include glucagon from alpha cells of pancreas, then epinephrine from adrenal medulla, growth hormone from anterior pituitary, cortisol from adrenal cortex. Hormones like this getting released into our bloodstream. This in turn result in a depletion of glycogen storage in our liver. Glucose is stored in the form of glycogen in liver as well as in our muscles. Whenever conditions like starvation occurs, this glycogen is getting utilized as glucose. Here, even though the blood glucose level is very high, because of the absence of insulin, the glycogen depletion start to appear. And this is called as glucogenolysis, that is depletion of glycogen into glucose. Again, gluconeogenesis is also occurring in liver. What is gluconeogenesis? That is, the formation of glucose from non-carbohydrate sources is known as gluconeogenesis. The raw materials for gluconeogenesis is supplied by our own muscles and also adipose tissue. The muscle start to break down the stored proteins into free fatty acids and amino acids. Again, the glycogen stored in the muscles are not only scarcely getting transferred into glucose, but it is getting transferred into lactate, because the last enzyme required for the conversion of glucose 6-phosphate into glucose is absent in the muscles. That is, glucose 6-phosphatase is absent in muscles, and due to the absence of this hormone, this is getting converted into lactate that we studied in Cori cycle. From adipose tissue, triglycerides will break down into free fatty acids. When all these free fatty acids getting accumulated in the liver, it will get converted into ketone bodies by the mitochondria of hepatic cells. This process is called ketogenesis, so that these free fatty acids can cause gluconeogenesis and ketogenesis in the liver. Ketogenesis will result in metabolic acidosis, and gluconeogenesis along with dietary glucose level causing hyperglycemia, which will result in symptoms such as glycosuria, polyuria, dehydration, polydipsia, susceptibility to urinary and genital tract infections, and later tachycardia and hypotension. This hypotension causes release of renin from our kidney, that is secondary aldosteronism, result in secondary aldosteronism. Because of hypotension, secondary aldosteronism develops. And this will in turn result in excretion of potassium through urine, and it will causes potassium deficiency. Then this unrestrained lipolysis and proteolysis will result in weight loss in case of type 1 diabetes. Thus, the patients usually present with a short history of hyperglycemic symptoms infections, and weight loss may have developed ketogenesis. Then, sir, is there time to describe about metabolic disturbance of type 2 also?
Yes, you can.
Okay, thank you. Metabolic disturbance in type 2 diabetes. Patients with type 2 diabetes have a slow onset of insulin deficiency. Relatively small amount of insulin is required to suppress lipolysis, and some glucose uptake is taking place in our muscles also. So that in contrast to type 1 diabetes, lipolysis and proteolysis are not occurring in type 2 diabetes, so that the weight loss and ketoacidosis seldom occurs in type 2 diabetes. Because of its insidious onset, most of the cases remain undetected. At the time of diagnosis, most are asymptomatic or give a long history of fatigue, with or without osmotic symptoms such as polyuria and polydipsia only. However, in some patients with type 2 diabetes present with marked osmotic symptoms and weight loss, this may be a late stage of it, such as already developed beta cell failure. As hyperglycemia worsens, the patient often craves sugar and will consume large volumes of sugary drinks to quench their thirst. Worsening hyperglycemia is also associated with increasing lipolysis, and high circulating glucose and free fatty acids are toxic to beta cells, resulting in glycolipotoxicity and decreased beta cell function. In these patients, ketosis and even diabetic ketoacidosis can occur in case of type 2 diabetes also. I think this is the time to stop this section. Let's discuss about the complications, its management, everything on the next topic, next session.
Yes, okay. Thank you, Dr. SREE LEKSHMI, for your nice presentation. You've done it very well. And we all know the importance of this topic, diabetes mellitus, because the number of patients are always increasing. Around 20% of persons in Kerala is under the threat of diabetes mellitus. So to manage such cases, we definitely need the basic knowledge, and also how to control such cases and how to detect the medicine, how to select the remedy. That's the most important thing. It's time for discussion. Those who would like to participate, please raise your hand. You can add something or you can ask some questions to Dr. SREE LEKSHMI. Mr. Taciturn, are you there?
Yan tarafı kilitledim. Good evening.
Yes, please. What is your comments on? Yes.
I attended very late. Thank you very much for this good explanation, but I'm waiting for the treatment management plans. So the second lecture. Thank you very much.
Okay, definitely it will be there. And Dr. SREE LEKSHMI.
Single session.
What about your
Because
part 2? Yes, Dr. SREE LEKSHMI.
Yes, next I will surely present it, sir, because this topic is so wide. I cannot finish it within this 45 minutes.
Yes,
That's why I split into 2 sessions.
this is only
Doctor, you can go ahead with it from 10 minutes so that more, so that we can have a clinical presentation and discussion on the second part. So better to go ahead with some more 10 minutes more. We have a lot of time remaining. That means nearly 20 minutes remaining.
Excuse me, sir. Just a minute. Can I take that book? Okay, let's talk about the complications of diabetes also. Okay, sir. Okay, sir. Is it okay?
Okay, yes, please proceed.
The most important complications of diabetes is considered into micro and macrovascular complications. The macrovascular complications can include coronary artery disease, that is, atherosclerosis of coronary artery can result in coronary artery diseases. I have already told that because of the high osmolarity of blood, atherosclerosis is occurring in different blood vessels of our body. So it is mainly occurring in coronary arteries also. This will cause coronary artery disease. When it appears, its manifestation will be like stable angina, unstable angina, myocardial infarction, sudden cardiac death. That is what I told that around so many persons are dying due to myocardial infarction, stable angina, like some, or they will tell like silent attack. But the main cause behind it could be diabetes mellitus. Then cerebrovascular complications. Then microvascular complication includes cerebrovascular complications also. It can act as a thrombotic or CVA, embolic CVA, stenotic or hemorrhagic. This trauma developed can mobilize from there and can become an emboli and can result in embolic cardiovascular accidents. Then this can act as a stenotic cardiovascular accident as the vessels are getting stenosed. The space for blood circulation is getting reduced. This can result in stenotic cardiovascular accidents. That is, stroke can occur in these type of cases. Then diabetic foot vasculopathy, diabetic foot ulcer. We all know, we all are regularly seeing diabetic foot cases because of the increased predilection towards infections also. This is increasing the chance to develop diabetic foot. The blood circulation towards the periphery is reducing, and also the blood our macrophages and our eosinophils are getting reduced. That is, immunity is getting reduced. All these contribute to the development of diabetic foot ulcers. Then diabetic renovascular diseases. It can also be come under microvascular as well as microvascular disorders. In microvascular disorders, renal artery getting affected. Atheroma is occurring in the renal artery, whereas in microvascular diseases, the glomerular capillaries are getting affected. That is the difference between renal affection of microvascular as well as macrovascular complications. Then about the microvascular complications. Microangiopathies especially occur in the capillaries. The microangiopathies of diabetes especially occurring to the capillaries of the blood vessels because of the non-enzymatic attachment of glucose or glucose products in the basement membrane makes it very thick, and because of that, its proteins are getting altered. The endothelial proteins are getting altered, and these capillaries are become very much leaky. That is, from blood, plasma proteins are start to escape through this leak, and over the time become irreversible. So in our eyes, it will result in diabetic retinopathy. It can, this microvascular condition can occur in different parts of our body. That all are diabetic, we are known as, it is known as diabetic retinopathy, diabetic neuropathy, diabetic nephropathy, all these things occurring due to these microvascular conditions. Then here in diabetic retinopathy, what's happening? Here in the retinal vessels here even causes microhemorrhages, and it can even result in the diabetic proliferative retinopathy, and which causes neovascularization of retina, and this even result in blindness. That is the later effect of diabetes mellitus on eyes. Blindness can even happen due to diabetes mellitus. This is how the most common cause of blindness is becoming the diabetic retinopathy. The next organ which can be affected with microangiopathy is our kidney, because of the presence of glomerular capillaries in the kidney. Then it is called as diabetic nephropathy, and it can result in end-stage renal disease. In USA, diabetic nephropathy is the most common cause of end-stage renal diseases. Then diabetic neuropathy, which affect the peripheral motor as well as the sensory nerves symmetrically. That is polyneuropathy. Classical examples are gloves and stocking syndrome. That is a symmetrical nerve damage occurs to our gloves areas and stockings areas in the foot. That is gloves and stocking syndrome. Then asymmetrical nerve damage also can occur in diabetic neuropathy, which is called mononeuritis or mononeuropathies. When it causes mononeuropathies in different areas, it is called mononeuropathy multiplex. Some other complications are also there other than vascular complications. That they are cataract. Even cataract can occur as a secondary to diabetes mellitus, as a long effect of diabetes mellitus. In repeated spikes of hyper and hypoglycemia, the glucose entering into our lens gets converted into sorbitol, and this sorbitol cannot escape from the lens during the hypoglycemic conditions. This in turn result in opacity of lens, and this in turn result in cataract. Then glaucoma. In advanced glycation products accumulation into trabeculae, which is the drainage of at the angle of the eyeball, there are some trabeculae for the drainage of aqueous humor. It will get obstructed due to the presence of advanced glycation products, and this will result in glaucoma. Even it can result in the damage of muscles of eyes. That is that is neuropathy. Neuropathy can occur in oculomotor and abducent nerves of the eyes, which is supplying the muscles of the eyes, and it can result in that strabismus, and also other conditions such as that are affecting the muscles of the eyes. Then I already told that infection. The patients are more prone to develop infections due to the destruction of immune system of our body, and also due to glycophilic microbes that is entering into our body. Then in the ear it can cause otitis externa, otitis interna. It all comes under the infection, but even it can cause sensory neural deafness due to the neuronal affections. In mouth, it can cause gingivitis. Even gastroparesis can result as a result of this diabetes mellitus. That is, autonomic nervous system in our gastrointestinal system getting affected with this diabetes and can result in anorexia nervosa, bulimia, and also all these things result in gastroparesis. In some cases, it will develop diarrhea, and in some cases, constipation also can result. Then erectile dysfunctions or impotence. It affects almost 30% of males. Then atonic bladder, inability to control our bladder functions. That can also result in occur as a result of diabetes mellitus. Shall we stop here, sir?
Yes, we can stop here and we can have another session. As we all know that Dr. SREE LEKSHMI has presented the first part of the same diabetes mellitus in a beautiful way. And of course, there will be a second part where she can come up with some cases as well as how the management of diabetes mellitus with homeopathy. As you all know, we can do a lot of wonders in management of diabetes mellitus, just like any other disorders. In the first part of the session, Dr. SREE LEKSHMI has mentioned that it is not simply a it is simply a disease, but it's a disease syndrome. As we all know that it's a lifestyle disorder, and being a lifestyle disorder, you need a lot of things to manage the diabetes mellitus. We need medicines as well as exercise, food management. Those are the not only that proper sleep and everything is required. So we will have a session in the coming month itself, so that you will get more ideas about the management as well as the treatment protocol of, as well as we all know that homeopathy usually treat the patient not rather than the disease. Of course, we all over the world, people are taking diabetes medicine every day, and day by day they used to increase, or month after month they may have to increase the medicine when they depend upon the other system of medicine. But if the person used to take homeopathy from the very beginning and go ahead with the homeopathic constitutional treatment, we were able to manage the disease. Even we were able to stop the condition of the diabetes person back to normal in some way or another. But there are exceptions also. But as we all know that there are different causes behind illness, and usually people come to homeopathy after taking a lot of allopathic medicine. So in those conditions also, we will have to manage in a different way. In those conditions, we used to give our homeopathic medicine along with the same medicine they are continuing. And once we find that the patient is improving, then we can reduce the medicine from the other side and go ahead with our own medicine. This is how we used to manage a lot of people depending homeopathy as well as eye system for their lifestyle disorders. Anyway, those things will be discussed in a better way by Dr. SREE LEKSHMI in the coming present session. Since we have cut short the discussion, for a few those who want to participate can also speak for a few minutes. I invite Dr. Ramparesh sir to say a few words on this session.
Thank you, Dr. Dhanesh ji, and Namaskar, Manoj ji, and Dr. Abdul Salam, Qatar. Congratulations, Dr. SREE LEKSHMI ji. Very nice presentation, excellent session, and deep and broad describe the diabetes mellitus, cause and effect. Very, very thanks. Our other session, second part of diabetes mellitus management, looking very good describe or deep
Thank you.
describe effect and cause. Very, very thanks, Dr. SREE LEKSHMI. Thank you.
Thank you, sir.
We invite Dr. Hariharan sir to say a few words. Just 3 minutes remaining.
No, I appeared because of to congratulate Dr. SREE LEKSHMI for her wonderful and she detailed pathology and the complication regarding diabetics. And please come to the next session with the management and the treatment. Really, you have a better future. You are a young lady doctor, and see all our blessings to you. Okay, thank you very much.
Thank you. Thank you.
It's the time to wind up the session as I invite Dr. Anju Roy from Qatar to say a vote of thanks to the session.
Audible, no?
Yes.
Good evening, everyone. It is my great honor to propose the vote of thanks on behalf of IFPH for today's insightful webinar on management of diabetes mellitus with homeopathy. Dr. SREE LEKSHMI, it has been an absolute pleasure to hear you present such an in-depth and comprehensive session on this important subject. Even though the subject is vast, we were unable to complete the session. Your presentation on homeopathy, especially that complications, was truly remarkable. The clarity with which you explains this complex concept has made this session incredibly valuable for all of us. As a proud student of Chada Krishna Homeopathic Medical College, it's a privilege for me to be here today on this platform alongside of my senior, Dr. SREE LEKSHMI. We would also like to take this moment to thank Dr. Abdul Salam sir, whose unwavering encouragement and motivation us to step forward and engage in such opportunities. Thank you very much, sir. Your dedication and guidance means a world to us. Thank you, sir. I would like to extend my gratitude to all attendees for your active participation and thoughtful questions. Also, I'd like to say special thanks to Dr. Danesh for the valuable explanation. Lastly, I want to express my sincere appreciation to everyone who contribute to organize this webinar. Your hard work and efforts in making this event a success and deeply appreciated. Once again, Dr. SREE LEKSHMI, thank you for your valuable time and insights. We look forward for more such learning experience in the future. Session from IFPH. Also, again, once again, thank you all.
Thank you.
Thank you, Dr. Anju Roy. Thank you, Dr. P. SREE LEKSHMI and Dr. Manoj and those who attend the session. And we will have a session from Dr. Sneha Haralkar tomorrow at the same time. The subject will be holistic health, exploring the physiological model through homeopathic case studies, and that will be the subject for tomorrow. And with that, we come to the end of the day 1595. It's over to Dr. Manoj tomorrow in the Malayalam session. Thank